So hello everyone, it's time, it's 5 p.m. So thank you all to be here today in this new webinar. And all Septodont team is also very happy and very honored to welcome Professor Taha. Professor, thank you so much for your participation. Thank you for sharing your experience with us, for bringing a new overview on irreversible pulpitis. We will have around 45 minutes today, followed by 15 minutes of questions. The mics are in mute, so please use the chat, and we will answer to all your questions at the end of the lecture. The webinar will be recorded, and we will send you the link to the video within 48 hours. Professor Taha, thank you again for this lecture, and the stage is yours.
Hi, Emily. Thank you very much for the introduction and for the invitation. Thank you also to Septodont for inviting me to the webinar. My name is Nasreen Taha, and I'm a specialist endodontist from Jordan. I had the chance to work on vital pulp therapy in the clinic and in research for more than 10 years now. And I'm happy to share with you my thoughts on vital pulp therapy, particularly pulpotomy in patients with symptoms of irreversible pulpitis. I just would like to declare that I have no conflict of interest whatsoever with Septodont, and I'm sharing my knowledge on calcium silicates, including biodentine, following the publication of 2 papers and a few upcoming ones on the topic. So thanks for your attendance, and I hope we will have a fruitful discussion on the topic at the end of the presentation. So as been advertised, we are looking at pulpotomy as a new clinical perspective on irreversible pulpitis, on teeth with irreversible pulpitis. Just a short introduction, just to introduce my country. I'm from Jordan, in the heart of the Middle East. To the west is Palestine, to the north is Syria, to the east is Iraq, and to the south is Saudi Arabia. If you haven't visited Jordan, you are most welcome to do so, and I encourage you after the finish of the crisis of COVID-19, and I'm sure that you will enjoy lots of places in Jordan, and you will also enjoy the hospitality of Jordanians. So traditionally, when a patient complains of a spontaneous pain, a prolonged pain, a pain that lingers, a pain that disturbs the sleep and affects the quality of life of a patient, the clinician jumps to the diagnosis of irreversible pulpitis and would recommend initiation of root canal treatment. This is what I was taught as an undergrad, and this is what's written in the consensus on diagnostic terminology by the American Academy of Endodontics and by the European Society of Endodontology. But as you go and practice, you start sometimes to think deeply and evaluate the application of such a diagnosis or such terminology in your practice, because when you say irreversible, it's not possible to change. It's something that's impossible to return to a previous condition. So it's a really tough decision to take with regard to pulpitis or with regard to anything in your life or in the medical fields. For example, if you have a pain in your knee, you go to an orthopedic, and he starts taking pain history. Does it hurt spontaneously? What's the movement that it hurts? But he will have to do lots of clinical examination and to explore the knee joints by tests like MRI, possibly computed tomography, ultrasound, and many special tests or injection before he decides that this joint is irreparable anymore, or it's not cannot be reversed or cannot be treated. So it's a tough decision, and before he could recommend replacement for the knee. So do we have all these diagnostic tests for a pulp in a carious tooth? And can we be sure that it's irreversibly inflamed to take the immediate decision of removal of the pulp? So if you have such a tooth with a big caries open to the oral cavity, and you see it's brownish to blackish texture, it seems leathery, soft, and it can be excavated. Can we condemn the pulp from this clinical photo and say that this is a deep carious lesion? The pulp must be irreversibly inflamed. Looking at the radiograph, you can see that caries is deep and it's almost exposing the mesiobuccal pulp horn or the mesial pulp horn. You look at the apices, they are incompletely formed. So here we have to do all possible tests to decide, can we preserve this pulp and promote further development of the tooth? We go back to the clinical history of the pain, and we also do our clinical tests. We do our cold test or electric pulp test. You use CO2 ice or endofrost, but you get a sensation. This sensation actually reflects the response of the A delta fibers, which is the innervation of the pulp, but it does not actually indicate the status of the vasculature of the pulp. So it's not 100% indication that this tooth is dead or irreversibly inflamed. It's unlike the test that we do in medicine for the knee example I just shown. So we have to collect all data to the before we decide and combine the history, the finding of clinical tests with our clinical finding after excavation of the caries. We have to follow this caries and see, assess the status, the clinical status of the pulp. Is there bleeding after carious exposure or not? Is it red? Is it yellow? So it's not a simple decision to go and remove a vital tissue from this tooth, because you will halt its progress and you will need to take special consideration for regeneration. So we cannot actually simply judge as it's an irreversible damage to the pulp. If we are going to review the response to caries, we have to remember when we have shallow extension of caries, it's considered as a mild stimulus that will induce a low-grade inflammation. Inflammation actually runs the process between repair and damage. So it induces odontoblastic rotary activity. There will be upregulation of the activity of these cells that will produce tertiary dentine, and it will bridge it from further irritation of the pulp. On the other hand, when you have a deep caries, the stimulus is more intense. It might result in death of the pulp cells, but at the same time, it will induce repair by stimulating progenitor cells recruitment, odontoblast cell-like differentiation. Fibroblasts may also take a role in this process, release of growth factors, inflammatory mediators. Again, we will reach to reparative dentinogenesis. However, when the intense stimulus is not removed, inflammation will progress and it will cause areas of necrosis. But what's the extension of these areas? How far is it extended? Does a carious exposure condemn the pulp as a doomed organ, not capable of repair? Actually, we have to look at detailed histology of such pulps before we go to this empirical decision that was stated by Rebel more than a century ago. So what's our knowledge on histology of the inflamed pulp? And what's the current position of the regeneration potential of the dental pulp? And in view of these, is there a conservative management for an inflamed pulp rather than simply pulling it out of a tooth? Early in 1980s, there was a paper by Damar et al. That looked at clinical signs and symptoms in pulp disease, and they were trying to find a histological correlation between the status of the pulp and the clinical signs and symptoms that the patient report. They found that pain was present in 40% of the cases in savable pulps. So it's not necessarily if the patient reports pain that this pulp cannot be saved, because pain threshold is also variable between patients. One will report severe pain while the other will report mild pain, while there is another person who will have a dead tooth, pulp is dead, negative response to testing, and without any history of pain. So it's not, pain is not actually a first indication for root canal therapy. And when they looked at 88% of painful cases, it had chronic partial pulpitis. Partial, it means it's not spread all over the pulp, so there might be a chance. Partial necrosis, again, the term is partial is there. Partial necrosis in 92% of painful cases. So we really have to go in depth to see the extension of this partial necrosis. And if we remove this area, can we save the remaining of the pulp? More recent studies using current techniques and serial sectioning with more accurate histological and bacteriological diagnosis are actually published by Dr. Domenico Ricucci. One of them was in 2014 when he looked at extracted teeth and he wanted to see the histology of cases with reports of clinical diagnosis of reversible pulpitis and irreversible pulpitis according to the clinical signs and symptoms reported by the patient. He processed the section for histologic and histobacteriologic analysis. He found that in cases of reversible pulpitis, the histology matches patient symptoms in 96% of the cases. So there is a good match in this. And in cases of irreversible pulpitis, he found matching only in 84% of the cases. 16% of the cases, there was no matching between the histology and the clinical diagnosis of irreversible pulpitis. But it's worth to mention here also, in this 84%, signs of inflammation were not totally spread throughout the pulp chamber of the tooth. It was very common to find areas of necrosis localized to the site of exposure or within 2 millimeters of the site of exposure, while the contralateral part of the pulp chamber and the pulp horn has completely normal architecture or just mild inflammation, which means the tooth might be actually saved, the pulp might be saved. These are radiographs and histology by Dr. Ricucci, again, very beautiful work, where he shows a radiograph of a lower wisdom tooth with deep caries, as you see in coursing on the pulp. This tooth, it's a wisdom, was extracted for other reasons, and it was it went under histologic examination. So this is a longitudinal section showing the caries in this area. If you can see in the histology, the pulp architecture is interrupted only in this spot. This pulp horn is beautifully there. However, we need closer look at histology of this area to see the extent of damage or extent of inflammation to the pulp in case of carious exposures and symptoms, clinical symptoms of irreversible pulpitis, which is severe pain reported by the patient and exaggeration of cold testing by the clinician. So this is a histology of the same tooth with a closer look. You see here interruption of the pulp, architecture, collection of inflammatory cells. But if you go to the other side, you can see cells lining the periphery of the pulp with no evidence of destruction. This is even a closer look of the healthy part of the pulp where there is no carious exposure. You see odontoplast lining the periphery of the pulp and normal stroma of the pulp tissue. This is another example of a root canal caries exposure in the pulp chamber. If we look at the histology inside the root canal, again, beautiful work by Dr. Ricucci. You see here beautifully the cells lining the peripheries of the pulp with the processes extending into dentine. So, do we need to remove the entire pulp from here, or would removal of this part give the chance to this healthy tissue to repair the wound and maintain the vitality of the tooth. This procedure will be termed actually by the AAE and the ESE as full pulpotomy, which involves the removal of the entire coronal portion of the vital pulp to the level of canal orifices to maintain the vitality of the remaining radicular portion. Although you could do partial pulpotomy by removal of the pulp horn from the area of the pulp exposure, but with full pulpotomy, you increase the chances that you've removed the entirely inflamed tissue and giving the chance of healthy tissue to repair the wound. So what are our aims from pulpotomy? First, we want to treat reversible pulpal injuries. If it's reversed, we aim also at neutralization of any existing pulpal contamination by removal of necrotic tissue, inflamed tissue, and by application of a biocompatible material that will favor repair rather than destruction. By this, we encourage continuation of root development in immature teeth, and we also have to prevent further contamination to maintain the repair and healthy status of the remaining pulp by an intact coronal seal that's placed as soon as possible after the pulpotomy procedure. In pulpotomy, proper case selection and proper treatment protocol, including material, are very crucial for success of the procedure. Diagnostic data should be taken in detail from the patient, and results of vitality tests should be, or sensibility tests should be documented. So you collect the triad of history, clinical examination, coupled with the radiographic examination as a baseline for diagnosis and follow-up procedures. When a patient comes with pain, his main concern is to get a pain relief. Is pulpotomy efficacious in reducing pain levels in symptomatic teeth with irreversible pulpitis? There is this study by Bergenholz. It's showing that it's looking at pain relief by pulpectomy versus pain relief by pulpotomy. And this is the preoperative pain level after pulpectomy. It's above 25%. If you perform pulpotomy, you achieve higher reduction of pain levels compared to pulpectomy. This was really of interest in the area of COVID-19. When you have an emergency patient and you want to minimize the time patient is at your practice, pulpotomy is actually indicated and its advantages in this term. You minimize treatment time, you minimize aerosol production, and you still can achieve pain reduction, which will relieve the patient and makes him happy. We don't need to forget challenging anatomy cases. If you have this case with a curved root, these are also curvatures. This is more severe curvature. Would you prefer root canal therapy, or would you prefer pulpotomy if it's feasible in this case? In many hands, root canal therapy is really can be performed to wonderful standards, preserving the curves, stellar puffs, excellent coronal restoration. And here I would like to thank Dr. Imran Zain Al-Abidin for providing these beautiful X-rays to include in my presentation, a colleague from Malaysia. However, in some other cases, you are not able to maintain the curve, and you end up with this procedural accident. You are causing ledging, transportation, and lateral perforation. So here it's more clear. What if we consider pulpotomy in this case? If the tooth is vital, obviously, and with a response to cold test, it's a very simple and reliable procedure to perform in one single visit, and you avoid potential procedural accidents. However, we should always remember that restorability is a prerequisite. I get this tooth, patient complains of symptoms of reversible pulpitis, I test, I reproduce by cold testing, but I shouldn't decide on performing pulpotomy before I take actually the X-ray and assess the restorability need of such a tooth. Most probably sometimes you will need retention from the pulp chamber or from the root canal. So you should plan your treatment according to the case. If I need the pulp chamber or the root canal for retention, pulpotomy is not indicated here for restorability reason, because I need to get my post and core placed. It's worth to mention that vital pulp therapy and the concept of preservation pulp vitality is not actually new. It started in the 18th century by gold foils over pulp exposure. Can you imagine this? But it evolved actually in the 20th century after introduction of calcium hydroxide. Look at this radiograph. There is this tooth with periapical lesion. Patient complains of symptoms of irreversible pulpitis. Is pulpotomy a consideration in this case, or this tooth is indicated for root canal therapy? When we performed a pulp test, we could reproduce patient symptoms. There is an exaggerated response to cold test, which indicates that there are vital tissues inside this tooth, despite the presence of periradicular radiolucency. We performed root canal therapy, and how long do you think that this review radiograph? It's only 3 months. 3 months after pulpotomy with periradicular changes, and we get a beautiful response. There might have been healthy tissue capable of inducing repair inside the tooth and shifting the environment towards bone filling of the resorption. So what's the available evidence on pulpotomy and in teeth with irreversible pulpitis and in teeth even with periapical radiolucency? The first review on the topic was by Akulik, Aguilar, and Linswanut in 2011, published in JOE. They showed that pulpotomy in young teeth with carious exposure and a diagnosis of irreversible pulpitis has a reported success rate that varies between 80 to even 100%. Furthermore, when you have teeth with irreversible pulpitis and periapical radiolucency, the pooled success rate from published studies, it's 92%. It's actually a very high percentage, almost comparable to that reported for root canal therapy. And there are lots of other studies in the literature, started in 1993 actually, in teeth with hyperplastic pulpitis. It's a pulp polyp in the pulp chamber. These teeth were treated with pulpotomy, even with calcium hydroxide, with long follow-up up to 4 years, and the success rate 91. Another study by the same author with a longer term follow-up. Further studies on irreversible pulpitis, so the concept is not actually new. In 2017, I published my first paper. It included teeth with both reversible and irreversible pulpitis. Success rate over 3 years was 90%. However, the majority of the cases were with irreversible pulpitis. So from that step, I decided to look in details on teeth with symptoms of irreversible pulpitis. There are furthermore publications on this. The first material used in vital pulp therapy was calcium hydroxide because of its high pH, antibacterial effect, and therefore the induction of hard tissue barrier formation. And it's cheap and readily available in almost every clinic. However, calcium hydroxide has high solubility. It has low mechanical strength. When you want to pack your permanent filling, you might result in disintegration of the calcium hydroxide layer, and therefore we lose what we are hoping to achieve, the tight seal and hard tissue barrier formation. There is difficulty in application on wet surface. It doesn't stick to a wet surface unless you have the chemical powder of calcium hydroxide and you want to use it. And histological studies by Nair and co-author found that even the hard tissue induced by calcium hydroxide, it contains tunnel defect. So it's not actually intact, and there is a risk of leakage if there is disruption in the integrity of coronal restoration. What are the recommendations of the European Society of Endodontology with regard to management of deep caries? I'm sure many of you have followed this statement. For direct pulp capping after pulp exposure, it's indicated in asymptomatic teeth or teeth with symptoms of reversible pulpitis. It's obviously based on histological findings that there is inflammation inside the pulp, and it's not possible to cap inflamed pulp infected by bacteria. Some tissue has to be removed to reach a healthy tissue that will start or induce repair. However, in symptoms of reversible pulpitis, they indicate that pulpotomy may be successful if performed under aseptic condition and magnification. Aseptic condition is a must. You have to disinfect the tooth surface, you have to apply rubber dam before you actually attempt caries excavation. But they concentrate on the word that may be successful based on the panel concluded that we don't have long-term follow-up studies, although we have results from 3 years follow-up and we have 5 years follow-up. I don't know how long follow-up we need to demonstrate to just delete the words maybe and just go on with pulpotomy. I know that there are currently now long-term studies being carried. I'm also doing long-term follow-up, so I hope that in 2 years' time, this statement can be modified. And it's worth to mention that now they are recommending calcium silicate-based material rather than calcium hydroxide based on low success rates in long-term follow-ups. But if you don't have calcium silicates, I still encourage you to use calcium hydroxide rather than pulling out the pulp. So there are several proposed prognostic factors for pulpotomy. It starts from preoperative, including pulp diagnosis, reversible versus irreversible, the periapical diagnosis, which means presence of periapical rarefaction or not. Sometimes they talk about age and root maturity as prognostic factors. But when I share with you now my studies later, you will see that I looked at these factors, and many studies actually looked at these factors, and I don't think it's a negative factor. Most importantly, intraoperative factors. You have to assess the remaining tooth structure. If you think the remaining tooth structure cannot be restored, tooth cannot be restored with a direct restoration, then you have to go to full root canal therapy. But if remaining tooth structure like this, intact, enough thickness of the cusp, I think we can restore this with direct restoration after our vital pulp therapy procedure. We have to look at the pulp tissue actually, assess it under magnification. Is it uniformly red? Can you see inflamed area, yellowish area, necrotic areas? Because this is contraindication if it's yellowish for pulp capping, for example. You get multiple exposures. If you are performing pulpotomy, it's not a worry. You just connect these exposure. Exposure size is not actually a prognostic factor, and it has been shown by many studies. If the exposure size is big, it's not a contraindication or a negative factor for pulpotomy. Capping material is really important because you want a biocompatible material that induce repair and bridge formation. Permanent restoration is really important. The most important prognostic factor for long-term success is the coronal seal in pulpotomy. Clinical procedure can be performed in a single visit or a two-step approach, although I prefer single visit because of the coronal seal. It's a must to do your cold test to establish sensibility. Local anesthesia and rubber dam isolation is a must from the start. Do not excavate caries and then expose the pulp, then apply rubber dam, because you've already introduced the risk of contamination. Sodium hypochlorite is the primary material we use in disinfection, although you can use chlorhexidine if you prefer. Sterile bird has to be used for establishing an outline of the cavity and caries excavation. Then you move to a new sterile burr when you want to cut the pulp. Disinfection of the cavity by rinsing with sodium hypochlorite is a must. You can use here low concentration of sodium hypochlorite just to disinfect the cavity after caries removal and before amputating the pulp. The next step is to achieve hemostasis, control of bleeding by a pellet pressure moistened with low concentration of sodium hypochlorite. I apply it, or most studies apply it for 2 minutes. With light pressure, you remove it and assess hemostasis. If there is hemostasis, we go to the capping material and the permanent restoration. If still bleed, I apply it more until 5 times, which is a total of 10 minutes. This is the exposure, fresh bleeding, and the cavity is caries-free. I rinse with sodium hypochlorite. We cut the pulp, fresh blood filling the cavity. If there is no enough blood, I will be concerned, because it means that the pulp might not be healthy. So you have to witness fresh bleeding, and then you have to attempt hemostasis. So this is fresh bleeding, cotton pellet, pressure, hemostasis, and this is a white MTA. When we first started with vital pulp therapy, we would place a wet pellet according to recommendation by Professor Turabenjad to ensure proper setting. But then after that, most studies are reporting enough moisture from the amputated pulp that it will help in the setting of the calcium silicate material. So you can actually finish it in one visit by placing Vitrabond liner, a resin modified glass ionomer, whatever you like, above MTA after initial setting. Then you acid etch and you restore with composite. This is a very old case with gray MTA in place. So how do we evaluate the success of the case? There should be absence of clinical signs and symptoms. Most patients, around 94%, report a complete relief of pain within the first 3 days after treatment. We do not expect a response to cold testing because it's a full pulpotomy. You remove the pulp chamber. We have to take a radiograph to assess absence of pathology in the root and the surrounding bones, and continued root development if it's an immature tooth. Hard barrier formation, you might see it or you might not, depend on the angulation of the radiograph. But if you don't see it, it doesn't indicate failure, because hard tissue barrier is actually a histological entity. It might be there and you won't see on radiograph. Length of follow-up, some studies report that 1 year is adequate, and there was no difference between 3 months and 1 year results. But the longer you follow the case, the better it is actually, especially for assessment of coronal seal. That's why most of the time I recommend crown placement, because it ensures better seal and long-term success. This is one of the very first cases when I started doing pulpotomy. The tooth was vital, deep caries. We need to keep this tooth because the patient is really young. None of the neighboring teeth has erupted. If we extract it, there will be a space loss and drifting and all these complications reported by pediatric dentists. So MTA was placed, permanent restoration by composite, space maintainer was cemented, and only 10 months after the procedure, you see how the root is continuing development. And this is actually, I can't do cold test on this tooth because the pulp chamber is already filled, but I can see sign that indicates healthy pulp inside the radicular portion. Otherwise, the tooth would have arrested its development. So our first study with my postgrad was on mature teeth pulpotomy using mineral trioxide aggregate. And we diagnose according to the accepted terminology by professional bodies. I want to show you that in this study, we included reversible pulpitis, only 8 cases, irreversible pulpitis, 43 out of 51 cases had symptoms of irreversible pulpitis, and we had some cases with apical radiolucency. These are some of the examples. See this tooth. Deep caries previously restored, recurrent caries exposing the pulp. MTA pulpotomy, amalgam restoration, tooth was crowned, and I have a long-term follow-up of 6 years for this tooth. Completely asymptomatic, patient is completely happy with it. This is another case published in International Endodontic Journal, and it was the cover of issue number 2 of volume 50 of the International Endodontic Journal, showing 3 years follow-up of MTA pulpotomy in this tooth with symptoms of irreversible pulpitis. Here you could see that there is a hard tissue between the caries, so there is no frank exposure of the pulp. However, when we attempt caries removal, there was a clinical exposure, and based on that, pulpotomy was performed. This is another case of a 3 years follow-up of irreversible pulpitis with periapical lesion, and this is beautiful healing. This is another example, and this is beautiful healing. We can see dentine bridging in this case. However, we have an aesthetic concern with MTA, which is discoloration. It usually starts as a mild, and with further follow-up, the patient will complain of unacceptable aesthetic. It's just because of the radiopacifier used in the white MTA version. This is in molar teeth. Some patients, they are still concerned because they think that something went wrong with the procedure that we performed. They think that the tooth is failing, the pulpotomy is failing. It's actually just discoloration from MTA, while radiographically there is success. Therefore, newer calcium silicate materials have considered one of the drawbacks of ProRoot MTA or other versions of MTA, which is the radiopacifier. For example, biodentine with Septodont, it has zirconium oxide, which will reduce or minimize tooth discoloration. It's already available in capsules, so it's minimize the variation from mixing of MTA and guarantee the mechanical and biological properties of the materials. And it has a short sitting time of around 12 minutes compared to 4 hours of initial sitting for MTA. There has been reports on biodentine and vital pulp therapy in direct pulp capping, caries exposure, and in asymptomatic teeth and in mature teeth. And there was case reports in traumatic exposure with good success rate. So I decided to test this material in teeth with irreversible pulpitis and frank exposure, and to look on in details on possible prognostic factors like is age a limitation, does caries extension matters, or does the type of caries as primary or secondary caries matter, preoperative pain levels, and the time to achieve hemostasis. So I had 2 publications with my postgrad student Taha on biodentine pulpotomy in symptomatic young permanent teeth with caries exposure and in adult patients with symptoms indicative of irreversible pulpitis, published in IEJ and JOE. The first one was in adult patients. We analyzed gender, tooth type, percussion sensitivity, as more than 50% of teeth with irreversible pulpitis, they report with percussion sensitivity, and I get lots of questions indicating, would you consider pulpotomy for a tooth with percussion sensitivity? We looked at presence of periapical rarefaction, at caries type, caries exposing the pulp, number of missing walls, and bleeding time control up to 6 minutes in this study. We found, this is 1 year result, we found at 6 months 98% success rate, and at 1 year follow-up we maintained this high success rate, and actually we just finished the we finished the 3 years follow-up actually, and we started the 4 years follow-up, and results and encouraging, and I hope to publish soon in the future. I'm sharing some cases of teeth with frank caries exposure of the pulp, biodentine pulpotomy. This is the biodentine material. I place it in bulk of 3, sometimes 4 millimeters. And this is the immediate post-operative. This is 6 months follow-up, and this is 1 year follow-up. Everything is fine. Tooth is asymptomatic, and there is dentine bridge formation here. The age of the patient is 23. And if you can see, there is furcation, radiolucency here, re-establishment, and here re-establishment of PDL space and maintenance of a healthy furcation area. This is another example of a wisdom tooth. So pulpotomy is perfect for saving wisdom teeth, caries exposure, and periapical radiolucency. At 1 year follow-up, PDL space is traced, amalgam filling. This is another example of a case where this previously restored, the pulp is stressed by previous restoration, recurrent caries, and leaky restoration. Pulpotomy performed, and it's beautiful. Look at the anatomy of this tooth. We avoided root canal therapy. And this is a long-term follow-up of one of the long-term follow-ups of biodentine pulpotomy after 3 years. This is biodentine, and see, everything is fine, tooth is asymptomatic. In young teeth, we also tried biodentine, and success rate was 95%. Here, the sample size was actually low compared to adult. The adult study, it was only 20 cases. But you can see here, destroyed tooth, immature apex, biodentine, continuation of root development. Patient is happy, parents are happy. This is another example of large caries, again exposing the pulp, biodentine pulpotomy, dentine bridge formation at 6 months and at 1 year in both canals. This is a case of 12-year-old exposure of the pulp with periapical rarefaction. This is immediate post-operative. This is 1 year follow-up, dentine bridge formation. There is widening of the pulp space in this spot. I was concerned maybe it's an internal resorption, but the tooth was asymptomatic and the parent opted further follow-up. And if you want to see long-term follow-up of the case, 4 years, there it is. Periapical lesion, large caries exposing the pulp, completely healthy. What I thought was internal resorption repaired. I can still trace the canal, I can see it. Some would say pulpotomy results in obliteration of root canals, and if you need to perform root canal therapy, it will be very difficult or challenging. I have not been faced in any of the cases I treated or I supervised, which is above 500 cases so far. And we actually performed root canal for some of the failed cases, and with magnification and current art of techniques and irrigation, it's not a real challenge to take your interest against pulpotomy. I was really happy and the patient was happy. This one I've just took this week actually for the patient. I will share another interesting one for the same patient. Look at caries exposing the pulp in the 5 and arresting root development compared to the other next door tooth. Caries again exposing the pulp in the upper 6. We performed pulpotomy first on this tooth. A week later, the patient came complaining of symptoms of reversible pulpitis in this tooth. We decided to attempt pulpotomy. We opened, we assessed the condition of the pulp. It's red, bleeding normally. Hemostasis could be achieved, so we performed pulpotomy on both teeth, and this is the 4 years follow-up. Continuation of root development in this, and healthy architecture of the periapical area, but unfortunately he's losing his spore. It's very hard for the kids to maintain good oral hygiene, and they don't attend regular visits. So I see him like 1 or 2 years only when I call him for a free review for the treated teeth. At the end, what I wanted to share with you is a beautiful diagram published in 2019 Journal of Dentistry by Domenico Riccocci on mature teeth with closed apices and carious exposure. Obviously, when symptoms of reversible pulpitis, there is a good agreement that if you get pulp exposure, you can do direct pulp capping with biocompatible material. If you can't, if you don't see a continuous architecture of the pulp, reddish, healthy, then you can go to pulpotomy. In teeth with irreversible pulpitis, you have to remove part of the pulp, either partially or completely, to reach a healthy tissue. I think that Dr. Riccocci, he states 2 minutes as a time limit for bleeding control. If you can't achieve hemostasis, you go to root canal therapy. And I discussed this issue with him, and he actually said it's just a note, it's not based on a big evidence. from literature published more than 20 years, and from my own papers, I can tell you that I published on hemostasis up to 10 minutes, which is 5 attempts of 2 minutes, and we get successful cases, and none of the factors that I thought would consider prognosis was significant except the coronal seal. It leads to late failure, actually. So he is more flexible with this time frame, and I am also much more flexible, and I can try up to 5 times, and you can try as long as you want if you have patience and dedication to perform the procedure. So my conclusion is regenerative procedure should be considered as the first line of management, and I will follow the ESE recommendation saying that over medium-term follow-up, it's highly successful. Pulpotomy using calcium silicate-based material is highly successful in teeth with irreversible pulpitis and apical periodontitis. And is it possible to save pulps? Septodont says it might not be too late to save the pulp. I totally agree with this, and I will expand this 5 minutes to 10 minutes to achieve hemostasis. Thank you once again for your attention, and I'm happy to answer any questions if you have.
Thank you very much, Professor. It was a really interesting lecture. And yes, we have some questions. So first one, can we place biodentin directly on the pulp?
Excuse me, Emily, can we place directly?
Can we place biodentin directly on the pulp?
I can't actually hear on the pulp. Of course, we place it directly on the pulp. Yeah, that's the procedure. You cut the pulp and achieve hemostasis, and then you mix biodentin according to manufacturer instructions of 5 drops in the capsule, triturate it for 30 seconds, and then you place it in thickness of 3 millimeters gently over the pulp. You count for 12 minutes from the time of mixing to the placement. Then you add your liner or your adhesive above it. Then you etch the cavity and restore it.
Thank you. What would be your lining material after you have done direct or indirect pulp capping?
These are 2 different stories. Indirect pulp capping, the pulp is not exposed. There are studies that show no difference between using a glass ionomer material or a calcium silicate-based material. But I personally prefer to use a calcium silicate-based material. But when you expose the pulp in direct pulp capping, in partial pulpotomy, in full pulpotomy, you have to place a tricalcium silicate material. You can't place a glass ionomer. It's irritating to the pulp. You can't place any material with resin because it's really toxic to the pulp tissue.
Thank you. Is it possible to remove biodentin material if tooth needs root canal treatment in the future? What is your experience in removing biodentin material?
Yeah. It's easy to remove, actually. It's just like cutting an ordinary cavity. I just use my diamond burr and cut it. And because dentin reported to have biomechanical properties similar to biodentin, to natural tooth dentin. So it's not actually difficult to remove. When you reach really deep toward the base of the cavity, toward the canal orifice, if you are concerned that you might perforate, you might change your burr to use an ultrasonic tip to remove it. But under magnification, you can identify it, actually. And it's easy. It's not challenging at all to remove. My students even could remove it.
Thank you. Have you seen any failed cases of pulpotomy with biodentin? What are the criteria to start root canal therapy?
The criteria is like any case of vital pulp therapy with biodentin or without biodentin. If the patient complains of pain localized to that tooth, then you get a clue that the treatment is failing. If you take a radiograph and you see signs of root resorption, signs of a new periapical lesion, then this indicates failure. If you find a sinus tract, a swelling related, any clinical sign of a failure will indicate the need for root canal therapy. And yes, I have seen some failed cases. There is no procedure that can be perfect 100%. But I can tell you that the majority of failed cases were related to a fractured coronal restoration and recurrent leakage. And in my coming study, I will include an analysis of the failed cases. I don't recall how many now, but if I say 98% at 1 year, so you expect it's only 2 or 3 cases out of the 60 that has failed. So it's not a high failure rate, and you can find also failure cases in root canal therapy or in any procedure.
Another question, can biodentin be a permanent restoration?
I don't think it's recommended by the manufacturer to be as a permanent restoration. You can use it as up to 6 months, I think, but then you have to top it up with another restoration. I haven't used it. I followed the manufacturer instruction, and you also need an aesthetic restoration. You have to add a crown or a resin-based material on top for aesthetic purposes.
I think that we come to the end of the questions. So thank you so much, Professor Taha. Thank you for sharing your cases and your long-term follow-up. We have seen healthy tooth. So thank you very much. And thank you all for being here during this webinar.
Thank you, Emily. Thank you, everyone, for attending, and have a great evening. By the way, this is, I'm not sure if you still see the photo. This is the campus of Jordan University of Science and Technology in Erbil. Have a great night.
Thank you. Bye.
Bye.